high level of LDL in blood and early cardiovascular diseases. The defects in the cellular receptors for LDL. Hence, LDL cannot be taken up normally by cells and degraded by lysosomal enzymes. The resultant increase in the blood LDL is associated with xanthoma, lipid deposit under the skin, and coronary artery disease. Treatment: low fat diet, HMG reductase inhibitors, statin, bile and bile acid binding regions, nicotinic acid. Atherosclerosis. It is the formation and deposition of lipid-rich plaques in the intima of arteries. It begins as fatty streaks containing foam cells, which initially are macrophages filled with lipids, particularly cholesterol esters. These plaques then become fibrous and may occlude an artery and cause a myocardial infarction or a cerebral infarct. The plaque formation is usually associated with abnormalities in plasma lipoprotein's metabolism. In contrast to other lipoprotein, HDL has a cardiovascular effect. Fate of cholesterol. 7-dehydrocholesterol in the skin is converted to vitamin D3 by the action of ultraviolet rays, sunlight, cholesterol synthesis, cholic acid, which take part in the synthesis of bile acids. Cholesterol is the precursor of steroid hormones, sex hormones, testosterone, estrogen, and progesterone, mineralocorticoids, and glucocorticoids. Blood. Blood is the fluid tissue which circulates in the closed system of blood vessels and chambers of the heart. Hemoglobin is conjugated proteins of RBC. It consists of heme and a proteins called globin. Heme constitutes about 4% of the hemoglobin. It is a complex of iron with the tetrapyrrole derivative known as protoporphyrin 3, also known as protoporphyrin 9. Globin globin constitutes about 96% of hemoglobin molecule. Myoglobin. It is a it is also called muscle hemoglobin. It consists of globin single globin chain which is combined with heme group. It is present in red muscle fiber. It combines with oxygen and forms oxyhemoglobin, which serves as oxygen reservoir within the muscle cells. Affinity of myoglobin for oxygen is more than that of hemoglobin, which helps in providing oxygen to the cells even at low oxygen pressure. It is more soluble than hemoglobin, that is why can pass glomerular membrane more easily than hemoglobin and appears in urine after severe injury to muscles. Liver. The liver is one of the largest gland of the body. It has a remarkable regenerative capacity. The function of liver will not be impaired even if a major portion of the liver is damaged. Blood flow through the liver is about 1500 milliliter per minute. The phagocytic cells of reticuloendothelial system of liver are known as Kupffer cells. Role of vitamin Role of liver in protein metabolism: ketogenesis, lipogenesis, triglyceride and lipoprotein synthesis, cholesterol synthesis, phospholipid formations, lecithin and scaffoldins, fatty acid modification, saturation, desaturation, shortening and strengthening of fatty acid chain. Bile pigment metabolism. Bile pigments are formed as a result of RBC degradation. These bile pigments need to be removed out of blood. Liver takes up these bile pigments and keep the blood free of them. Once these bile pigments are taken up by liver cells, it conjugates them with glucuronic acid. Liver then secretes these conjugated bile pigments into the bile and stores it in the gallbladder. Bile acids and bile salts metabolism. Liver conjugates cholic acid and quinodeoxycholic acid, bile acids with glycine and tyrine. Bile acids are then secreted in the bile as sodium salts, bile salts, bile synthesis and secretions. Bile is synthesized about 15 to 23 ml per hour. It is secreted through hepatic ducts into the gallbladder, erythropoiesis. During इंट्रायूट्राइन लाइफ लिवर सिंथेसाइजेज आरबीसी, जो हम कहते हैं कि लिवर जो है वो खून बनाता है, तो ये आमतौर पे इंट्रायूट्राइन लाइफ के अंदर ऐसा ही होता है. डिग्रेडेशन ऑफ सिनाइल आरबीसी. Comfort cells destroy senile and abnormal RBC, resulting in the formation of bilirubin and release of iron. Storage. Liver stores vitamin A, D, K, B12, folic acid, iron, glycogen, and blood. Synthetic functions. Liver synthesizes urea through urea cycle. Vitamin D, 25-hydroxycholecalciferol from cholecalciferol. Plasma protein, albumin and globulins. Clotting factors, fibrinogen, prothrombin factor 8, 7, 9 and 10. Lipoproteins, glycogenesis, glucogenesis, glycogenolysis and gluconeogenesis. Ketone bodies means ketogenesis, triglyceride means lipogenesis, cholesterol, phospholipid and bile acid. Bile salts. Excretion. Bile is the main excreted product of liver. Cholesterol, bile acid, bile salts, phospholipid, many drugs and their metabolisms are excreted in bile by the liver. Detoxification. Detoxification can be done by four processes: conjugation, hydrolysis, oxidation, and reduction. Liver also inactivates several hormones. Liver converts toxic substances like indole, scatol, ammonia, dopamines, drugs, food preservative to non-toxic compounds. Activation. Liver activates many inactive drugs to their active form, activates vitamin D, a conversion of cholecalciferol to 25-hydroxycholecalciferol. लिवर फंक्शन टेस्ट, जिसको हम LFT कहते हैं. These can be classified according to the physiological functions of the liver. Test for carbohydrate metabolism. Intravenous galactose tolerance test. Normally, liver converts galactose to glucose very rapidly. No galactose should be present in the blood 75 minutes after an intravenous injections of galactose in a dose of 0.5 gram per kilogram body weight. In liver damage, rate of conversion of galactose to glucose is decreased, and therefore galactose will be found in blood after 75 minutes of intravenous injections of galactose. Response of glycogen to adrenaline. Normally, fasting blood glucose level should rise by 45 milligram per 100 ml of blood after subcutaneous injections of 0.01 milligram of adrenaline per kilogram body weight. No response is seen in patients with type 1 glycogen storage disease, von Gerke disease, who lacks the enzyme glucose 6 phosphatase. Test for protein metabolism. Plasma protein determination. Only liver produces plasma albumin and fibrinogens. Their liver falls in severe liver disorders, cirrhosis, and hepatitis. Response of prothrombin to vitamin K. Liver in response to vitamin K forms prothrombin. No response will be seen in liver disease, and hence no prothrombin will be formed. Prothrombin time. The time required for coagulation to take place is known as prothrombin time. Prothrombin time gives an indication of the total quantity of prothrombin in the blood. If prothrombin is deficient, the time of coagulation will be considerably prolonged. Test for lipid metabolism. Detection of serum cholesterol level. Increased serum level of cholesterol and cholesterol esters are seen in biliary obstructions, obstructive jaundice, mainly because of the failure of the excretion of these substances in the bile. Test for bile pigment metabolism. Vandenberg's reactions. It is a test to differentiate between conjugated and unconjugated proteins. Vandenberg reactions, a solution containing bilirubin is added with diazo reagent. If the solution gives violet color within 30 seconds, it is called direct VDB reactions. If there is no color change within 30 seconds, then alcohol is also added. If the solution bilirubin plus diazo reagent gives violet color after adding alcohol in it, it is called indirect VDB reactions. This is because alcohol sets bilirubin free from its complex. Total serum bilirubin is about 0.3 to 1.1 milligram percentage. Indirect VDB reactions detects unconjugated bilirubin. Therefore, unconjugated bilirubin is also called indirect bilirubin in blood. Unconjugated bilirubin is bound to albumin and therefore is water insoluble. Indirect bilirubin represents the fraction of bilirubin before entering liver. Normal level of indirect bilirubin is about 0.2 to 0.7 milligram percent. If indirect bilirubin level is high, it means that either liver is unable to take up bilirubin at a pace it is synthesized, or liver cells are inefficient in taking up the bilirubin, or there is a deficiency of enzyme response for conjugation. Direct VDB reactions detects conjugated bilirubins and therefore conjugates bilirubin is also called direct bilirubin. Conjugated bilirubin is conjugated with glucuronic acid and therefore is water soluble. It represents the fraction of bilirubin which has entered liver. Normal level of direct bilirubin is 0.1 to 0.4 milligram percent. If direct bilirubin level is high, it means that liver is unable to excrete conjugated bilirubin in bile due to either obstructions, for example, gallstones, cholelithiasis, or defect in the transport of conjugated bilirubin from the hepatocytes into the bile canalicules. Jaundice becomes visible when total serum bilirubin exceeds 2 to 3 milligram percent. Beside liver disease, jaundice may also be noted in hemolytic disorders such as hemolytic anemia. Detection of urinary bilirubin. Presence of conjugated bilirubin, water soluble in urine, is normal. Presence of unconjugated bilirubin, water insoluble in urine, is abnormal and always indicates disease. Abnormality is seen in hepatic and post-hepatic or obstructive liver disease. Estimation of urinary urobilinogen and urobilin. In this test, amount of urinary urobilinogen is estimated. Normal value is 0.4 to 0.5 milligram per day. Increased urobilinogen and urobilin is seen in hemolytic conditions in early stages of liver disease. Decreased urinary urobilinogens and urobilin is seen in gross biliary obstructions, malabsorption of urobilinogen by the intestine in diarrhea, and administration of broad spectrum antibiotics. The antibiotics prevents the conversion of bilirubin to urobilinogen. Fecal urobilinogen. Increased fecal urobilinogen shown by dark colored stool is seen in hemolytic diseases. Decreased fecal urobilinogen shown by clay colored stool is seen in bile duct obstructions, obstructive liver disease, for example, cholelithiasis, or failure of the liver to excrete bilirubin. Test for detoxification functions of the liver. Hippuric acid. Liver detoxifies benzoic acid by conjugating it with glycines, forming hippuric acid. After giving a test dose of benzoic acid, amount of hippuric acid formed is determined after 1 hour. In liver disease, amount of hippuric acid will be decreased. Test for the excretory functions of the liver. Bromsulfaline test. 5 milligram per uh, kilogram body weight of BSP is injected intravenously after 45 minutes. 5% or less of the injected dye should be retained. Retention of dye more than 5% indicates the presence of liver damage. Bilirubin test. 1 milligram per kilogram body weight bilirubin is injected intravenously after 4 hours. Not more than 5% of bilirubin should be retained. Retention of bilirubin more than 5% indicates liver damage. Test based on enzyme level. Increased serum alkaline phosphatase level is seen in acute liver disease, obstructive uh, jaundice. Increased serum glutamate pyruvate transaminase in SGPT is seen in liver damage, cirrhosis, or hepatitis. Increased gamma glutamyl transferase level is seen in alcoholic liver disease. Decreased serum cholinesterase level indicates liver disease. Liver biopsy is it is very helpful in diagnosing liver disease, cirrhosis, hepatitis, cancer. Liver scanning, it helps in sorting out the normal and diseased parts of the liver. Bile pigment metabolism, degradation of senile or old RBC. Normal lifespan of RBC is 120 days. After 120 days, RBC dies and is taken up by reticuloendothelial system present in liver, spleen, and bone marrow. RBC then dissociate into its component and undergo oxidation and reduction reaction. HB is broken down to globin and heme. Globin is reutilized along with other proteins of the body. Heme again dissociate into iron and porphyrin ring. Iron goes to liver and bone marrow to be reused for the synthesis of hemoglobin and other iron-containing substances like cytochrome. Porphyrin are degraded to form bile pigment. Bilirubin and its fate. Bilirubin is lipid soluble and water insoluble. Once bilirubin is formed, it is released in the blood. It combines not covalently with plasma albumin. This combined form of bilirubin with albumin is known as unconjugated indirect bilirubin, which cannot pass into glomerular filtrate. Thus, it cannot appear in urine even at a high level in, for example, in hemolytic anemia. Uptake of bilirubin by the liver. Bilirubin plasma albumin complex is taken up by liver cells. In liver, bilirubin dissociates from albumin and combines with the protein called ligandin. Conjugation of bilirubin with glucuronic acid. Intrahepatic bilirubin then reacts with two molecules of glucuronic acid and becomes conjugated and in direct bilirubin as bilirubin plus UDP glucuronic acid is found bilirubin glucuronide.